Hospitals, Vadaparani has been doing excellent work with respect to the Department of Neurosciences. We also offer deep brain stimulation. We also have screening camps done amongst the elderly to pick up Parkinson's disease. I'm Dr. Subha Subramanian, consultant neurologist at SIMS Hospital. With me is
Dr. Vivek Iyer, consultant neurologist, SIMS Hospitals, Vadaparani.
We are going to share our insights about Parkinson's disease. What do you think about the REM Sleep Behavioral Disorder?
The REM Sleep Behavior Disorder, we ask the history of REM Sleep Behavior Disorder to patients who have motor manifestations who have come to our clinic. They say that these symptoms have been there 5 or 10 years earlier before the motor symptoms started. So it is a very important and a robust clinical marker as far as non-motor symptoms are concerned. Typically the patient, the wife or the spouse would say that they act out of their dreams. They have thrashing movements of the hands, which is what we call as dream enactment. They move their limbs in sleep. They may even spouse or the partner next to them, they may even injure when they are moving their hands or thrashing the sleep. What is your take on the drug-induced Parkinsonian syndrome?
Yes, that is one of the causes contributing to Parkinsonism. We all know that antipsychotics have side effects. They can cause drug-induced Parkinsonism. But one of the commonest causes of drug-induced Parkinsonism is prokinetic drugs. You know that patients go to a gastroenterologist with problems of indigestion, they end up getting a prescription, but then they don't go back to the doctor and end up taking prokinetic for a long period of time. So prokinetics like levosulpiride are notorious to cause drug-induced Parkinsonism.
Particularly in a setting of elderly people wherein there is a lot of polypharmacy involved.
Exactly. As we were discussing about the non-motor symptoms, decreased cognitive decline is also quite common in Parkinson's patients. We all know about the other kind of dementia. So what is your take on Parkinson's disease dementia, Dr. Vivek?
Yeah. Parkinson's disease dementia per se, the dementia, the memory issues, the cognitive decline sets in around 5 to 7 years after the motor symptoms have started. And particularly the patients would have recent memory issues. They will have difficulty in planning and organization. Like many patients would complain that they are fumbling to do a particular task which they would do easily. So as you rightly said, as the disease evolves, along with the non-motor symptoms, the higher functions, the cognition also takes a hit, which has to be looked for in subsequent follow-ups with the neurologist.
So we have to keep following up for that also.
Yes. But how do we proceed evaluating these patients with Parkinson's when they come to our clinic?
As you rightly said, yes, it is a clinical diagnosis. It all solely depends on the neurologist taking a call. But having said that, we still go around doing basic blood investigations. We would like to do an MRI, brain imaging basically, to rule out other diseases that can mimic a Parkinson's, like a normal pressure hydrocephalus, vascular Parkinson's, some of the Parkinson plus syndromes. So we would like to know what we are dealing with more in terms of the kind of management as well as in prognosticating the patient. Parkinson plus also comes and confuses the picture most of the times. Sometimes what we think initially is Parkinson's may not be Parkinson's, or we may miss the Parkinson plus syndromes. So can you tell me something about the Parkinson plus syndrome?
So Parkinson's plus syndromes, the main point or the main reason why we need to diagnose and pick up early is because generally, by and large, they have a poor response to dopaminergic therapy, that is a cornerstone of treatment for the idiopathic Parkinson's. So along with the slowness and the bradykinesia rigidity, they will have bladder bowel involvement. So urinary urgency, urgent incontinence, and profound fluctuations in blood pressure, what we call as orthostatic hypotension. So they may feel dizzy or may black out or zone out when they are standing up after a long time. As against that, as we know in progressive supranuclear palsy, they may have repeated falls because they are not able to move the eyes up and down or sideways. Bulbar involvement, what we say as choking and aspiration tendency to liquids and solids, begins earlier in these Parkinsonian plus syndromes, particularly progressive supranuclear palsy rather than idiopathic Parkinson. Thank you.
Thank you.